talk. So, opioid epidemic and cancer pain care lessons from converting policies into practice. And I know a lot of you are systems level, researchers and would be very interested in learning about your perspectives. But what I'm presenting here is my perspective about almost what I can call the life cycle of a guideline or a life of a guideline that was very influential in shaping clinical pain practice. So these are my, disclosures, but I would like to conflict with NIH some more. I think academics understand what that means. So the outline, I'll start with a larger context of chronic pain management in the United States. I will make the case, I don't know how many of you are familiar with the 2016 CDC opioid guidelines for chronic pain. So I'll make a case that there were broad misapplications of this guideline, which undermined care of patients with moderate to severe chronic pain, including cancer pain. And it further widened racial and ethnic, as well as socioeconomic disparities. And as you guys know, those overlap significantly in the United States. And then I'll finish with talking about obligations of policymakers in scaling high-stake policies. So this is Human Rights Watch, a number of different reports featured here. So in the last decade or so, the Human Rights Watch has come out with different reports about the state of pain treatment globally. So for example, countries like Kenya, India, Armenia, and most of the suffering that they have uncovered is related to severe lack of opioid availability for pain relief. And I think a lot of you already know about the disparity in opioid access by developed versus developing countries. In 2018, the Human Rights Watch actually investigated United States policies for pain management. And they concluded that recently those same stories have been coming out from pain patients in the United States. Very similar. So you see this photo on the screen. Basically, all of this hardware came out of a chronic pain patient. And this patient was denied opioids, which made the patient bedridden and completely limited her function. So this is the famous or the infamous CDC guidelines for prescribing opioids for cancer pain. They came out in 2016. It had 12 recommendations about when to initiate or continue opioids, opioid selection, dosage, duration, and discontinuation, and then assessing risks and harms of opioids. So those were the set of domains that they investigated. The three important things to remember about these guidelines is that they were meant as voluntary, because we'll come back to this. They were meant for primary care providers who treat chronic pain, and they were meant for chronic pain. So just remember these three things as we progress. They simultaneously disseminated the guidelines in two different venues. So it was the MMWR reports that CDC puts out regularly, as well as a briefer report in JAMA. And they fully disclosed the level of evidence that these guidelines were based on. So as you can see, it said evidence consisted of observational studies or randomized clinical trials with notable limitations characterized as low quality using grade methodology. So the evidence were generally low quality. I did my own synthesis of these guidelines and their recommendations. 84%, so they had 31 different outcomes. Of these, 84% were based on type 3 or type 4 evidence that would be considered studies with notable limitations or clinical experience only. and 16% with insufficient evidence, which essentially means that they had no studies. For example, they had 0 studies about outcomes of opioids for pain, function, quality of life, long-term, which means more than 3 months. Nevertheless, so despite the evidence, the low quality of evidence of these guidelines were rapidly adopted as evidence-based and across sectors, and I will show you these data. So I show altmetric scores here, and as academics, I know the jury is out on altmetric scores, but they do give you a sense about the uptake of an article. So, or a dissemination piece. So here, you see an altmetric score of 3,657. That's outrageous, actually. So these are the #1 scoring guidelines. So the CDC guidelines for opioid prescribing are the #1 scoring guidelines that CDC has ever put out in terms of its uptake. And it's, the last time I checked, it was the second highest scoring from JAMA that JAMA has ever put out. So these are very highly received guidelines, and they were like wildfire in terms of their reach and adoption. Now, CDC, like I said, they had 12 recommendations. One of their recommendations was about caution for the first time, there have been many cancer pain guidelines, that have been available for many decades, but never before any guideline has talked about dose thresholds in terms of opioid prescription. So for the first time, CDC opioid guidelines came out with dose thresholds, and they said you should use caution with doses more than 50 morphine milligram equivalent per day, and avoid or carefully justify more than 90 morphine milligram equivalent per day. So avoid or carefully justify. So from a behavioral economics perspective, it's like putting a lot of onus on the clinicians for prescribing doses beyond this. As I said to you earlier, that these were meant for clinical practitioners. They were meant as voluntary. Nevertheless, there was misuse and unintended use of the guidelines very early on since the guidelines were published. So the guidelines were published in March of 2016. In August of 2016, this comment was published in JAMA in response to the article. And they said that, today I received 8 more letters from an insurance company containing forms for me to complete because they believe that 16 milligram of sublingual buprenorphine exceeds your MME. So this astute clinician predicted that very soon, insurance companies and, all the different stakeholders are going to use these thresholds as cutoffs for reimbursement or payment or filling prescriptions, etc. And this clinician was not incorrect. So, and just so you know about buprenorphine, some of you, if you're clinicians, you know that it's a partial agonist, which means that, you cannot apply the MME conversion, the morphine milligram equivalent conversion that you do for full agonist opioids. You can do it with partial agonist opioids. So it was whoever was sitting and making these decisions, they didn't even understand clinically, that, this is not an appropriate application of MMEs. So there were more issues going on here than just, insurance companies requiring this documentation. Health plans and insurers, they came up with, a number of limits on opioids. So Cigna no longer covered opioid prescriptions exceeding 90 morphine milligram equivalent per day. Anthem reduced opioid prescription by 30%, actually well in advance of their goal, like in terms of the timeline. Blue Cross limited initial dose to less than 5 days. And Medicare Part D plan required clinicians. So consulting prescribers. So the pharmacy would consult the prescriber before filling a medication that is opioid, that is 90 morphine milligram equivalent or more. States. So again, recall that these guidelines were meant as voluntary, and they were also based on very limited set of evidence. At least 33 states adopted legislation or restrictions related to opioid prescribing. And just so you know, just so you can understand how quickly this progressed, in early 2016, only Massachusetts had a law about limiting opioid dispensing to 5 days. Between 2016 to 2017, there were already 130 bills in 30 different states. And by 2018, 33 states had enacted laws already, limiting days of supply of opioids or restricting the morphine milligram equivalent per day. And this restriction actually led to patient dumping. So I'll show you data on that. But this led to widespread inappropriate tapering of opioids, for patients who are exceeding 90 morphine milligram equivalent per day, and sometimes outright just dumping of chronic pain patients. So this is a very interesting study. It was published in 2019. They used data from 2013 to 2017. And they used data from Medicaid claims data in Vermont for patients who were on high dose opioids, so doses that were 120 morphine milligram equivalent per day or more. These researchers found that the median time to discontinue opioids was 1 day. Now, you guys are familiar that opioids, that's not appropriate clinical practice because you need to taper off opioids. You can't just discontinue opioids, right? So the median day, so essentially what it means is that for 50% of the patients, there was no tapering of opioids. There was just outright discontinuation of opioids. Also, interestingly, less than 1% of patients were transitioned to opioid use disorder treatment for these. I see some shaking heads, and those are very much appropriate. So, and these researchers also showed that rapid discontinuation was associated with the highest opioid-related adverse events that they defined as emergency department use or acute hospitalization. And going back to the story that I'm telling here, majority of the tapers occurred from 2016 to 2017. I should say taper and discontinuation because half of the patients didn't get any tapers. This was a study that was conducted by Pain News Network just 1 year after the CDC guidelines were published. And they found that they surveyed both patients and clinicians, and about over 3,000 pain patients. And they found that patients said that their quality of life was worse. A high percentage of patients, I'm no longer prescribed opioids. That's almost 1 in 4 patients said that. I'm prescribed a lower dose, which is half of the patients said that. And I've considered suicide, which is, 2 in 5 patients almost saying that. Providers said that they lost 10% of them said that they actually lost a patient to suicide. So this is not attempted suicide. They actually lost a patient. 10% of the providers said their patients committed suicide. Insurance refused to pay for a patient's treatment that clinicians thought, they should have had. 57%, and a pharmacy refused to fill opioids. That's, almost, so that's almost 60%. So you can see the broad impact that the guidelines had on chronic pain patients. Now, this slide, I would just like for us to unpack a little bit because, every time we hear about opioid epidemic, we think of it as prescription opioids, right? How many of us think of it as prescription opioids? And that's what we hear in the media and in clinical practice, etc. So what you see here is that, this blue line is your natural or semi-synthetic opioids. So these are the opioids that are prescription opioids. And you can see that even before, like at least from 2011, this has plateaued, plateaued, and then slight, this has remained almost very similar up until the CDC opioid guidelines have came out. And the actual culprits, so to speak, are two medicines here, which are two drugs, which is heroin and illicitly manufactured fentanyl, right? These are not prescription opioids. So even before 2016 guidelines, the majority of opioid epidemic was actually driven by these two. And most importantly, as you can see, almost from 2013, almost like a straight line, this is illicitly manufactured opioids. Interestingly, CDC, up until 2015, CDC combined illicitly in reporting their numbers of opioid epidemic. They did not unpack the illicitly manufactured fentanyl, which is not prescription opioid, and the prescription opioids. Now, I'm from Pakistan originally, and I know that Pakistan neighbors Afghanistan, and we have the hugest shortage of opioids for pain relief and for patients who are dying. But I also understand, how when governments cannot, when governments don't have leverage over illicit market, they go after illicit market. They go after legal system that they have more control over. And honestly, US is no different in terms of how it is managing the opioid crisis, because it's going after, this line here, which has been stable for a very long time and, very much ignoring the other trends. And if you think about the illicit market in the United States is $150 billion a year. The amount of money that the feds actually spend on drug war per year is $35 billion. So you can see, it is a lot of money, but it is dwarfed before, the illicit market. And obviously it's a failed drug war. We all know that, the death rates keep rising. But basically, they're doing what Pakistan has been doing, going after the illicit market, even when we are the opium producing country and also, neighbor Afghanistan. So it is a very interesting trend to know what is going on. Now, after the 2016 guidelines, actually, the death rates on opioids increased 10% worse than the previous year. So it actually didn't do anything in terms of saving lives. And the worst toll, so this is, they came out with a report, the CDC came out with a report, and they said that new data is showing complexity. That's a very gentle way of putting that the guidelines actually did not do anything. But that was probably too early. And then it got complicated with COVID. So we don't know what would have been the actual trends, but the numbers keep going up every year since the guidelines have come out. And the largest percentage change in terms of opioid involved death have been with Black patients. And it is a relatively underappreciated fact. So it has the largest percent increase. And we can talk about why that is the case, but those are the data. Now, another trend in the same graph that I showed you, another trend that does not get appreciated is the cocaine trend. And as you can see, this is, if you see like these data are converging, like these things, prescription opioids, heroin, and cocaine. I mean, you can see they converge here, and the cocaine trends they keep going up if you can see the trend. But we never hear about cocaine epidemic. Have you heard about cocaine epidemic? Cocaine epidemic, maybe a little bit, but not much, not to the extent that we hear about the opioid epidemic. And there is a good reason for that, because it affects mainly Blacks. And you can see, these data are from New York, so your town, and basically you can see that the overall drug overdose deaths, were, so these are rates. These are not crude numbers, but rather rates. The rates are higher for Blacks for drug overdose. You can compare these graphs, but you can see that the cocaine is what is afflicting, or illicitly manufactured fentanyl or heroin, but cocaine for Blacks, but prescription opioids or other illicit opioids for whites. And there are also differences by age types, ranges. So Dr. Patrice Harris, who is the former president of AMA, she pointed out in one of her talks that she said that we don't have an opioid epidemic, we have a drug overdose epidemic. And that's how we should be addressing it, and not necessarily just the opioid epidemic. So this was the background, like the larger picture. And now coming to palliative care, the guidelines were misapplied. So this is the Health and Human Services Pain Management Best Practices Interagency Task Force report. And essentially it came out in 2019, and they concluded that the guideline was misapplied to palliative care populations. And that was partly based on some of the work we did that I'll talk to you about. So just so you understand, the patients who were within the scope of the guideline. So the guideline excluded patients cancer patients who were receiving active cancer treatments, like, chemotherapy, radiation, surgery, actively, they were excluded. But the guideline also excluded end-of-life care patients. But the guideline included patients who were cancer survivors with chronic pain. And they explicitly said that, cancer survivors with chronic pain were within the scope of these guidelines. So we published this paper in JAMA Oncology, and this was a commentary, but it had a lot of legs because it synthesized, the issues that nobody was talking about at the time, which was, the guidelines applied to cancer patients who were beyond active treatment arbitrarily, and without any, the guidelines were essentially agnostic in terms of evidence to cancer patients. There was confusion and conflict with major national cancer pain guidelines, and some key recommendations were simply, they could not be applied in clinical practice. So I'll break each of these down. So we looked at all of this. So I presented these data and other at the National Comprehensive Cancer Network meeting by invitation. And at this meeting, the NCCN, the American Society of Clinical Oncology, the American Society of Hematology, as well as the CDC guideline authors were there, as well as Scott Gottlieb, then the chief, executive of FDA. So this was a meeting by invitation, and we were invited to present because of the, article we published and some of the advocacy work that we did. So essentially, as you can see, in the entire guideline outside of the description of the scope, where they talk about the inclusion-exclusion criteria, there is no discussion of cancer pain, like zero mentions. And they did not synthesize any evidence around cancer pain. Their key questions were inappropriate. So this is one of their key questions. In patients with chronic pain, what is the effectiveness of long-term opioid therapy versus placebo or no opioid therapy for long-term, more than 1 year, related to outcomes? I mean, how absurd is that? Can you see how absurd is that? Because I'm sorry, I'm not trying to be provocative, but I'm just trying to be reasonable here. For patients, for chronic pain patients and for cancer patients, opioids are indicated for moderate to severe pain. We all know the 3-step analgesic ladder that WHO is still used in the clinical practice. So it is for moderate to severe pain. So it would be ethically, you cannot find a single study that actually would randomly assign patients to a placebo, like chronic pain patients who have moderate to severe pain. This is their key question number 1, by the way. So I'm not going further in the details of other questions, but this is their number 1 question. So this, you can probably extrapolate from this. So no IRB or no ethical review committee is going to approve of a study that compares chronic pain patients receiving placebo or, the other, the arbitrary, nature that I talked about. This is the American Cancer Society study, 1-year longitudinal study of cancer survivors in terms of their symptom burden. And this is a very well-conducted study, longitudinal study. We have very few studies like that, but they found, as you can see, I highlighted pain here, there is no difference in terms of symptom burden between patients who are receiving active treatment, which was a group excluded from the CDC opioid guidelines, and patients who have completed their treatment. Sorry, I moved. Who have completed their treatment. And the treatment burden is very comparable and sometimes, even more because of the fact that, a lot of pain syndromes that are developed for cancer patients, they occur after they complete the active treatments because, they receive radiation or chemotherapy or surgery, which has long-term implications in terms of pain. And for example, chemotherapy induced neuropathies and surgically induced, chronic pain. So this is very commonsensical data. Another issue we identified, this table was not in the paper, but this was presented at the meeting. But essentially, you have these long-standing existing cancer pain guidelines, the American Society of Clinical Oncology, the National Comprehensive Cancer Network guidelines. And there is a lot of there are a lot of differences in how, each guideline is talking about the same patient population and treatment. So just to give you one example, the CDC opioid guidelines said that concurrent use of extended release or long-acting opioids and immediate release opioids should be avoided. In the NCCN guidelines, they talk about, that's a preferred practice because you want to control the background pain so that patients don't have, a lot of episodes of breakthrough pain. So that's the mindset there. And you can see that, there are no mention of dosage thresholds and some other, nuanced differences between the guidelines. I think the most importantly, the number 1 recommendation that they had was, this is their first recommendation, that non-pharmacological therapies and non-opioid pharmacological therapies are preferred for chronic pain. And this, some of you who are clinicians, you probably know that this is very difficult to implement in clinical practice if you want to achieve adequate pain relief, because a lot of insurance companies, your most major insurance, Medicare, it does not cover acupuncture other than for chronic low back pain. It doesn't cover acupuncture for cancer pain. So that's your, Medicare insurance. These are our data. This is just preliminary data, so not, hold me hold me to these because I'll be presenting more up to date. But based on the preliminary data, you can see that evidence-based alternative treatments are limited, period, meaning it doesn't matter which race or, it's just limited, but it is specifically limited by race. So only 3% of African Americans in our study reported, receiving acupuncture, which, is being touted as one of the evidence-based treatments for cancer pain. Similarly, cognitive behavioral therapy, which is another evidence-based treatment, only 3% of whites and 5% of blacks, reported receiving that. And these are patients with pain, because that's our inclusion criteria. These are cancer patients. So here I discussed to you and described to you about the non-opioid, non-pharmacological treatment for pain, and you can see disparity broadly, but also by race and socioeconomic status. And we have published extensively about, I'm just featuring two of my articles here, but others have published about this, and I've conducted a meta-analysis, and essentially, we already have disparities, huge disparities, significant and meaningful disparities in treatment of pain using analgesics. So add on the top of it, the non-opioid, non-pharmacological treatment. So it just creates a very, and even when, in terms of analgesics, even when African Americans or Blacks are prescribed opioids, they are not clinically appropriately managed. And that's what our study in the Journal of Clinical Oncology has shown. So we argued in that JAMA Oncology paper that, first of all, we called for the CDC, ASCO, and NCCN, to convene, and this is where, they actually, I received a call from Dr. Bob Carlson, who is the CEO of NCCN, and he said that your article has not gone unnoticed. And the meeting I described was a result of this article. And then, in that article, we basically said that, you cannot change a pain management paradigm, without adequately supplying another. So you just can't make a recommendation, adopt it, and it's not transferable to clinical setting. Another thing I think that what the guidelines did, it worsened the stigma, opioid stigma, which, as we know, there is always opioid stigma, but it's my perspective that it worsened it. So this is CDC's campaign. And like you can see, they show a bottle with very few opioids, and they say it only takes a little to lose a lot. And this is a one-size-fits-all type of campaign. And, everybody, they did not have a disclaimer. I presented these data at the closed meeting. And after this, if you go to the website, they put a disclaimer about, some patients needing opioids, but it was not there when I presented the data. So they use a one-size-fits-all type of approach to their campaigns, which stigmatized patients who needed opioids to survive and function. This is a study that we did using American Cancer Society funding, and this was a mixed method study. And you can see how stigmatized patients feel. They were like, I was literally trying to see how long I could go between pain pills. I mean, it was just stupid. I do not use them. I have them for mental backup. So if I feel that I'm in a real bad situation, I have my medicines right here. The other thing we uncovered from our the same study, qualitative work, is that there were a lot of unsafe practices that patients were engaging in by themselves. So self-management of opioids, and things that they reported doing was, they were using they were cutting opioid pills. So you know that cutting a long-acting opioid pill can be very dangerous because it releases a very big dose of opioid into your system and can cause overdose. So patients were doing all kinds of things. They were self-tapering opioids. They were using extended release opioids on an as-needed basis, which, we published another study in which we showed that 1/3 of patients have 7 days of consecutive days of gap between their 2 opioid doses. Now, why is it important? It is important because there is something called opioid tolerance, right? And you have to be taking 60 morphine milligram equivalent of opioid dose for a week to be considered opioid tolerant. So if you stop using opioids and say you are prescribed, say, a quantity that you were tolerant to before, but now you go back to that dose after becoming, losing tolerance to that dose. So this can now cause. So this is also something that we published, and there's actually 0 studies out there that have done that kind of analysis, because in another study we found that inconsistent use of strong opioids was the strongest risk factor for hospitalization in our patient population. So there is a lot of unsafe clinical outcomes occurring as a result of opioid fear, opioid stigma. And patients also talked about combining Tylenol, over-the-counter and over-the-counter anti-inflammatory agents like, ibuprofen. And again, you guys probably know that's not the safest, practice. So patients are coming up with all kinds of, their own approaches to self-manage their pain and to avoid using opioids until they are absolutely necessary. So as a result of, that meeting, the article, an effort was launched by the NCCN, ASCO, and American Society of Hematology. They sent a letter to CDC to clarify their guidelines that includes cancer patients as part of their, and patients with sickle cell disease as part of their guidelines. And this was sent in 2018, November 2018, and then April 2019, the CDC issued a clarification that essentially said that, for cancer pain management, you should rely on the professional organizations and their guidelines for management. So they're essentially excluded. But it took CDC almost more than 3 years to come up with official clarification of the guidelines. So in the New England Journal of Medicine, in 2019 on the top, Dr. Deborah Dowell, the chief author of the guidelines, she published No Shortcuts to Safer Opioid Prescribing. HHS published guidelines for how to taper opioids appropriately, and also cautioned against abrupt because, there is wide-scale evidence of patient dumping, like I showed you the Medicaid population study in Vermont. So basically, they were very late in terms of clarifying the misapplications of their guidelines. Now, this presentation is timely because in 2022, as we speak, CDC is revising its guidelines, and that was one of the recommendations by the Human Rights Watch report and many professional organizations, and to revise the CDC guidelines. And they've used a process that they had previously used, actually, which starts with AHRQ doing systematic review of the evidence. And the guidelines are expected sometimes in 2022. We are coming very close to the end, so they are expected anytime. And one small win, so to speak, is that they explicitly excluded patients with sickle cell disease and cancer, cross trajectory from the scope of their guidelines. Some of the key changes that that I synthesized, and this is the proposed guideline. So mind you, this is the guideline based on, that they had proposed that was open to public comment. So this is not the final guideline. But they explicitly said that this is not meant to apply to patients with cancer, sickle cell, or end-of-life pain. The chronic pain population, the chronic pain patients are saying, why cancer is different? We are suffering, like I showed you, the hardware that came out of, one chronic pain patient. So, but they did explicitly exclude those populations. I think that was a very wise thing to do. They put no hard ceiling for what clinicians can prescribe. So that is, I think, probably the most important recommendation, because as you know, it led to outright, very inappropriate discontinuation and taper of opioids. They also talked about no arbitrary time limit for acute pain. I didn't mention this, but if you recall the earlier slide, the guidelines were meant for chronic pain, but they were applied for acute pain setting as well. So they revised in terms of, and came up with 3 different definitions of pain. So acute pain is up to a month, then subacute pain is 1 to 3 months, and then chronic pain is up to 3 months and above. And the guidelines propose that there will be no arbitrary limit for acute pain, which is less than a month, based on how they define it. They also explicitly talk about, how and when to safely taper opioids, and then clinicians should not abruptly reduce opioid dosages. One epidemiological trend to watch for, and I hope somebody is doing this study, which is pain chronification. Because how there is enough literature to suggest that if you don't treat pain acutely, it transitions to becoming chronic pain. And the way acute pain is treated these days, it is so amazing. My father had an open heart surgery. It was an opioid-free open heart surgery. Can you believe that? And he received very minimum. He had major, all the 9 yards. And he received, I had to literally, but he's a very little man. He's very small man. He weighs 46 kgs, 96 some pounds, 94, 95, 96 pounds. He was receiving 975 milligram of Tylenol every 6 hours. For a person, so anyway, I would say that another incidence to watch for is end organ insufficiency or end organ failure at the population level among patients who have been prescribed, who have been tapered from opioids, because that's what they've been given, to manage their pain, or they're self-managing their pain that way. So a lot of damage to be tracking. So in the interest of time, I'll just quickly go over these recommendations and then I would start. So these recommendations are for policymakers. So, but I would say that a lot of what happened, they were foreseeable risks. And for the new guidelines, anticipating and addressing foreseeable risks to public, patients and subgroups. Now we are all, researchers. Most of us are. We do a small, clinical study, observational study. We have to go through IRB and we have to say that, we have to make such a strong case for no harm, even in minimally risk observational studies. And here you're doing a public experiment with, there are 40 million people with chronic pain. you're doing a public experiment without any regard to, how would you manage those risks when your voluntary guidelines become legislation, and become hard limits. And then monitoring early trends in guideline uptake. So they were celebrating that, the guideline uptake, like I showed you, even within the 5 months, there was such a huge uptake of the guideline. And CDC was celebrating it. Actually, they were celebrating and congratulating all of these stakeholders in terms of their uptake. But sometimes, very rapid uptake is not a good idea because you are not able to monitor, its misapplications and the damage that it can potentially cause. So there should be some sort of a moderate pace of uptake, which also should include, monitoring how the guidelines are affecting the public. So being nimble and being honest in calling out, because some of these were baked, some of the misapplications were baked in the guidelines, like I showed you, the key questions and things like that. Also, in terms of consumer, being very astute, because a lot of people just, we hear the word evidence-based guidelines. That's how they are selling these guidelines. That's how everybody's consuming evidence-based guidelines. Yes, there is evidence, but it's poor. So as a clinician, you should be able to call upon and also system level changes, because I'm not going into the details of that, but a lot of systems actually implemented it also as hard limits on the systems level in their opioid stewardship programs. And very important, low barrier access to non-opioid, non-pharmacological pain treatments, more research on that, because, some of the meta-analyses done, they suggest that they don't work as well as opioids do in relieving pain or relieve it for a very short term. And you can't go for acupuncture, you can take opioids, but you can't go for acupuncture, every second day, right? if they work for short term, or massage therapy is a better example, I think. So, and this opioid stewardship programs that are popping up throughout the country, they should include outcomes such as pain function, reducing stigma, beyond the simple stated goals of reducing opioids, because currently opioid stewardship is like a code word for limiting opioids. So all of these other outcomes should be included as part of these programs. And that's all I have. Let me see.
Thank you so much. It's really, really great. I'd like to invite some comments. If anybody has any comments, I'll start. I mean, I learned so much, so thank you. I wanted to ask you one question about, which is my lack of knowledge in this area. You showed these death rates on opioids. Was that just for opioid overdose, or was there some people with cancer are going to die on opioids? That how was that handled? Do you know?
Yeah, so these are drug overdose deaths. That's a very good question. I think these are drug overdose deaths. So those patients would not be included as part of that. But I'll tell you one more nuance to not drug overdose death, but rather how they calculate, how they compute misuse. Okay. All of my patients would be characterized as misusing opioids if the way the question is phrased in the CDC survey, when they identify misuse, the national drug use data. Basically, the question is, are you using opioids as prescribed? Mm-hmm. Now, our patients are underusing it. They're not using it as prescribed. They're not overusing it. But based on that question, they would be characterized as misuse.
Oh, wow.
Yes. So it's like a complete, needs a lot of work.
Yeah.
The way that we are doing the reporting.
Yeah, and then the other question, which you touched on, was because one of the questions I wrote down, should we advocate insurers or CMS to pay for acupuncture and CBT? And, you're sort of yes, but it's not going to work for everybody. Just your thoughts on that.
So just last week, the American Society of Clinical Oncology included acupuncture and massage as part of its recommendations based on, some synthesis of evidence. So I think that once the professional organizations, oncology organizations are going to make those recommendations, I think that's probably the strongest lobby for Medicare to start thinking about paying for that. But right now, it's mostly out of pocket, or very few insurance would cover it. And it's a lot of haggling that patients don't have or clinicians don't have the bandwidth for.
And the health disparities that go along with that, absolutely. Are there other questions from other ones? Marlene?
I just want to say something. I have to get back to clinic. Thank you so much for this. I mean, this was 10 years of practice for clinicians who really, really struggled. And, we've taken care of patients with chronic cancer pain on opioids for 10 years who are highly functional and participate in society. And what we were being told is everyone needs intranasal Narcan. Now, that's a whole other question.
Right.
But, I think that this is a real testimony in history to saying a group of clinicians continually said this didn't make sense. And what I found, I worked at Montefiore during this period, is the voice really came out of the substance abuse community.
Yes.
And the substance abuse community was seeing patients who had advanced cancer because they were drinkers and smokers, and they were seeing these patients and they were saying, this doesn't make sense. And so Joanna Starles, who I worked with, was really a leader in starting to say, what are we doing here? And I think that when we look back and reflect in what happened here, this was the perfect storm. There was 60 Minutes, everybody was, being interviewed, and the doctors who were taking care of sickle cell being put in prison. But I really think that this was a group of people who stood by their grounds and said, this doesn't make sense. And to see the article in JAMA in August, I don't know if you guys are familiar with, I'll put it in the link. That was shocking. We were seeing our patients commit suicide.
Right.
We were seeing this every day and no one was listening. And all we were being told is order intranasal Narcan.
Right.
So this is going to show something in history. And it really shows clinicians who stood their ground and were afraid to say, this doesn't make sense.
Yes. And a lot of communities, like oncology clinicians and substance abuse and patients, primary care docs who treat long-term opioid, not necessarily overlapping with substance use disorder. And there was a recent case where $7 million worth of settlement. And I think that got a lot of attention.
I agree with that.
Because you have to have accountability. And I think in all of this, accountability was the thing that was missing from all levels. So thank you so much, Marlene, for your wonderful comment.
Thank you for doing this work. And as a nurse, I mean, I think
you went on mute.
I think the voice of a nurse is so important in this, and saying, wow, we really got to think about what we're doing.
Yeah. Well, thank you both for the comments. I do want to remind, we're at the top of the hour, so I'll be very quick. We do have a December enrichment program, and we won't have one in November. And it's going to be Carl Hart and Craig Blinderman, and they're going to be talking about LSD we don't actually have the title, but it's about LSD use in palliative care. So it should be very, very interesting. So thank you all, and have a good